Bismillah ar-Rahman ar-Rahim. Welcome fourth year EMP students. This is my third recorded lecture prepared and presented by me, Dr.KHALED DIAB, an OB/GYN professor at Ain Shams University Hospital. Hope you find it useful and helpful. I will share with you the following slides that will review an evidence-based updates on clinical management of labor induction, labor augmentation, and pre-induction cervical ripening. By the end of this presentation, the students should clearly understand the following ILOs. The presentation will follow through the following heading titles: an overview on basics of labor induction, labor augmentation, the indications, the contraindications, and the outcome. It will cover the prerequisite methods and labor management in cases of labor induction and labor augmentation. The basics of parturition and labor were given in previous lectures and should be revised by the student. Labor induction is an intervention designed to artificially induce uterine contraction with the aim to achieve vaginal delivery before labor is started. Labor augmentation, on the other hand, is an intervention to enhance uterine contraction after the labor contraction has already been started, with the intention to achieve vaginal delivery. The indication of either will follow. Labor stimulation is synonymous to labor augmentation, yet it is used by some to denote natural method or stimulation of uterine contraction after rupture of membranes, believing that with rupture of membranes, labor has already been started. Cervical ripening is a process of induction of labor that results in softening, effacement, and dilatation of the cervix, making it ripe, so that later process of induction of labor will be more successful. Induced labors represents about 10 to 20% of all deliveries related to the countries and hospital practice. The following are the main list of methods used for induction of labor. Details will be given later in this presentation. As for the procedure indication, labor augmentation is indicated to correct uterine dysfunction during labor with the intention to increase progress and achieve vaginal delivery. Cervical ripening methods are interventions used to improve cervical condition to facilitate dilatation once labor is established and increase chance of vaginal delivery. As for induction of labor, it is indicated when potential benefit of termination of pregnancy outweigh possible risks of continuing pregnancy for various maternal, medical, obstetrics, and fetal indications. Common indications are past date, intrauterine fetal death, pre-labor rupture of membranes, antepartum hemorrhage, and hypertensive disorders with pregnancy. Elective or social indication with no clear maternal or fetal indication should be avoided, especially before 39 weeks due to increased maternal, fetal, and neonatal risks. The following table shows absolute and relative contraindication for induction of labor. Absolute contraindications are mainly those that contraindicate vaginal delivery, while relative contraindications are conditions whereby caution should be taken due to associated increased risk during labor induction, which may be related to a specific candidate or a specific method of induction of labor. The parturient should be properly counseled for the pros and cons of induction of labor. Her refusal is considered a relative contraindication. When comparing different protocols for induction of labor, outcome measures include: first, the success rate percentage. Overall, induction of labor will achieve 60 to 80% spontaneous vaginal delivery, and about 10 to 20% will have assisted vaginal delivery, while cesarean section rate ranges from 10 to 20%. Failed induction should only be diagnosed in the active phase with cervical dilatation more than 6 centimeters after 12 hours of rupture of membranes. Second outcome measure is induction delivery interval. Successful vaginal delivery is usually achieved within 12 to 24 hours. If prolonged, it will lead to mothers with dissatisfaction and, of course, increase maternal, fetal, and neonatal risks and complications. Of course, the cost of the method used should always be considered. As regards risks and complications for labor induction, this may be related to the procedures or the induction method or to the indication whereby labor is induced. For prolonged labor with induction delivery intervals more than 24 hours, it will require more epidural, more operative vaginal delivery, and more cesarean section. Furthermore, prolonged labor may result in increased maternal infection and increased maternal dissatisfaction. Also, uterine risks include uterine tachycystole, as defined as more than 5 contractions per 10 minutes, or uterine hypersystole or hypertonus, as defined by uterine contraction lasting at least 2 minutes, or hyperstimulation, which is tachycystole or hypertonus associated with non-reassuring fetal heart rate pattern, and fetal compromise do occur. Hyperstimulation of the uterus may also result in increased uterine rupture and postpartum hemorrhage. The risks related to the procedures examples as with artificial rupture of membranes, there is increased risk of cord prolapse, and with oxytocin use, a maternal water intoxication is a rare complication. Lastly, inadvertent delivery of preterm infant may be the results of induction of labor if expected date of delivery was not correctly documented. Prediction of successful outcome is important during counseling for induction of labor. Predictors of success include maternal characteristic, fetal gestational age, yet the main predictor is pelvic examination and calculation of Bishop score, originally reported in the 60s, items with the scores of 0 to 3 with several modifications. The first modification is replacing the percentage effacement with the cervical effacement in centimeters. Score less than 3 is considered unfavorable, while score more than 9 is favorable. A simplified modified score, Calder score, is used with scores 0 to 2 each items. Maximum is 10, with score more than 6 is considered favorable. Transvaginal sonography and cervicovaginal fibronectin has been investigated, yet not evident proof to be valuable factor related to prediction of success of induction of labor. Unsuccessful induction of labor is anticipated in nulliparous, past date, oversized baby, and low Bishop score. The following slide shows prerequisites for labor induction. Of course, all induced labor should have a continuous intrapartum electronic fetal monitoring during active phase. The frequency of fetal monitoring during cervical ripening is related to the parturient characteristic, the method used, and the indication. All inductions are carried out in hospital. The possibility of having cervical ripening during outside hospital will be discussed in the next face-to-face session. The following slides show various methods for labor induction, mostly mechanical and pharmacological. Historical or natural methods are listed, yet not evidence-based. For each method, the student should know its value, its indication, and whether it is used as labor induction or labor augmentation or cervical ripening. Also, its effectiveness and safety and how it is used. A clinical protocol of use for each method should be known by the student. The use of balloon catheters and laminaria may result in cervical softening, effacement, and dilatation with fewer or no systemic effects. The probable mechanism of action is local prostaglandin production. Balloon method have the advantage of cost effectiveness and presumed safety in the presence of a uterine scar. Mechanical methods are not likely to be effective in inducing labor on their own and often require oxytocin for induction or augmentation. Sweeping of the membranes may promote the onset of labor by increasing local production of prostaglandin. Discomfort during vaginal examination and other adverse effects such as bleeding or irregular contraction were more frequent in women who had the procedure performed. ARM or amniotomy is one of the commonest procedures performed in obstetrics. It is often used in conjunction with oxytocin for labor induction or labor augmentation. After amniotomy, the amount, color, and consistency of the liquor is noted, which may help in the assessment of fetal well-being. Care must be taken in cases of high presenting part due to an increased risk of cord prolapse, whereby controlled ARM should be done. The potential risks related to the mechanical method is listed in the following slides. Pharmacological methods are mainly subclassified into either prostaglandins or oxytocins. For prostaglandins, either dinoprostone prostaglandin E2 or misoprostol prostaglandin E1 may be used. Prostaglandin F2 alpha is currently not available. Different clinical forms are available with different routes. The optimal dosing and the available trade names for different prostaglandin used are shown in the following slides. Only one form of prostaglandin E1 misoprostol and 3 forms of prostaglandin E2 dinoprostone are available commercially. Prostaglandin E1 analog misoprostol is a synthetic prostaglandin which is marked as an anti-ulcer agent under the trade name Cytotec. It may be used either orally, sublingually, rectally, yet more effective vaginally. 25 microgram vaginal tablet is also available. The dose frequency of its use is related to the route used and the clinical indications and women's characteristics. Note that the FDA classifies Cytotec as a pregnancy category X drug. 3 forms of prostaglandin E2 dinoprostone are available commercially: vaginal tablets, vaginal gel, and vaginal mesh. The trade names and dosing is given in the following table. The major risk of the above preparations is uterine hyperstimulation. The woman and fetus must be monitored for contraction, fetal well-being, and changes in the cervical Bishop score. A discussion of the use of prostaglandin as a pre-labor induction ripening method will be presented during the face-to-face session, during which the students are encouraged to read and prepare from the suggested reading, the suggested text, a clinical protocol. Intravenous oxytocin has been widely used since 1950s for induction of labor. It has a half-life of 5 to 12 minutes, a time to steady plasma concentration of 40 minutes, and a steady-state uterine response of 30 minutes or longer. It is only used by intravenous infusion, mostly using an intravenous pump. The ideal dosing regimen of oxytocin is not known. However, it has been found that increasing the dose no more frequently than every 30 minutes resulted in fewer episodes of excessive uterine activity, a higher rate of spontaneous vaginal delivery, a lower rate of postpartum increased maternal infection and postpartum hemorrhage, and a trend toward a lower rate of cesarean delivery. 2 main protocols are used, either low or high dose protocols for labor induction or labor augmentation. The starting and the incremental increase is shown in the following table. A discussion on the use of oxytocin as labor induction and labor augmentation will be presented during the face-to-face session, during which the students are encouraged to read and prepare from their suggested text a clinical protocol for clinical use of oxytocin in labor induction and labor augmentation. Suggested frame for an algorithm or a protocol for labor induction, labor augmentation, or pre-induction cervical ripening is presented in the following table. During the face-to-face session, together with students, such protocols will be discussed. Grand malkipra and scarred uterus represent a relative contraindication or caution for labor induction. Selection of the method for labor induction will be discussed in the face-to-face presentation or with other topics. The student should be able, guided with previous slide, to summarize for each procedure the possible methods and their safety and effectiveness. The student is advised to prepare this clinical case for discussion in the next face-to-face session. Hope this presentation was clear and helpful. The student is advised to read the recommended text and see YouTube links and be prepared with the questions and discussion in the next face-to-face session. Thank you for your time.